All right, yeah, so thank you very much. We are now going to start with today's topic, looking at the management of a high viral load in pregnancy. Please do engage with us on the chat, but importantly, share your questions through the Q&A section of the platform so that we are able to engage further. So by the end of today's session, I would like you to be able to know practically how to approach an HIV positive pregnant mom who's not suppressed. You need to be able to describe, the correct monitoring of pregnant women who are living with HIV and AIDS who are on ART, and to know exactly what to do when now they present with a high viral load. This is very, very, very important. And obviously, some of the concepts they build on the previous master classes we've been having around treatment failure, first line, DTG. But today we won't go that deep because we have to deal with issues around pregnancy. So when you look at the recent antenatal survey published last year, but representing data up to 2019, you would see that over the years, we have had a rising prevalence of HIV in pregnancy, stabilizing around 29%, but over the last 4 or so consecutive years, we are still at around 30%. And this is a very important number because it tells us that almost every third pregnant mom you are going to see in your clinic where you work is likely to have a positive HIV test. And remember, HIV testing is the door, it is the entry point into HIV care, particularly in pregnancy. Our failure to test women would mean that we would not be in a position to provide life-saving interventions for our mothers. So I'm not sure about stabilizing at 30%. I still feel that it's too high. It would have been better maybe at around 10, 5%, if not even zero, because ultimately what we want to get to is a situation where we have zero mother-to-child HIV transmission. And the more we are able to keep women HIV negative, it is the more we are likely to win this particular battle. The same report then looked at the provincial data, and you would see that, yes, the national average is about 30%. But if you are joining here from KZN, you would see that the province has just crossed 40%. That means almost every second pregnant woman might be presenting, with HIV. Eastern Cape as well at 36.5%, followed by the province I'm presenting from, 34%. So these three provinces are probably significant contributors to the burden of HIV in pregnancy. And there's no way that you could be working and operating in these provinces broadly in the country if you do not have the necessary knowledge and competence to manage HIV broadly, but particularly for pregnant women. And you would see that they subclassified into first visit and those who were tested during the follow-up. Depending on the province where you are from, you might find that, for example, if you look at Mpumalanga, most women are tested positive during a follow-up ANC visit versus presenting for the first time pregnant, already knowing their status. So these are some of the sub-classifications you can look at in interpreting this particular data. Again, going into specific districts, we won't go through all of them, just to look at the top 5. You'll see that Ugu, Umgungundlovu, Zululand, eThekwini, so on the top 5, 4 of the 5 districts are from KZN. Chris Hani is in Eastern Cape, Amajua is KZN, and then Mpumalanga, they're probably on number 8 or so. So this just tells you that the biggest burden of HIV in the country, the epicenter, is in KZN. And if you are a health professional working in that region, you should have HIV on your fingertips, because there's no way, whether you're working in surgery, orthopedics, you are going to interface with an HIV positive patient who's got a broken bone or who's pregnant. So Mpumalanga, Eastern Cape, and KZN, these are the provinces we need to be watchful of. They further looked, comparing 2017 and 2019 to say, are we doing the right things? If you look at the testing for pregnant women, it's high. So almost all of them, it's not 100%. Actually, if you look at some of the provinces, they underperformed and so on. But all in all, our testing coverage in pregnancy is very high. So we should clap hands for ourselves. And graph B there showing the proportion, of women who tested positive, who were initiated on ART. And again, in excess of 90%, 95%, some provinces very close to 100%. So why is this topic important? I mean, we are testing everyone, we are putting everyone on ARVs. So what are the issues? And really here is the issue, which we also discussed on Monday, if you missed that particular talk. And if you remember, you know where to get the recordings and, but, if the red there, that is the issue, what we call non-pregnancy related infections and their contribution to maternal death. So if our pregnant women are tested and they are subsequently put on ARVs, why do non-pregnancy related infections continue to contribute to maternal deaths? I mean, in KZN, your non-pregnancy related infections are the leading cause of maternal deaths at 24%. Look at Limpopo there, 34%. That's a third of all maternal deaths. It's got something to do with infections that are not associated with pregnancy, and predominantly it has to do with HIV. So if you look at the Limpopo, KZN, Eastern Cape, Northwest, Mpumalanga, a little bit low, but it's still a quarter of all maternal deaths, where the contributory factor has got something to do with a woman who is HIV positive, who falls pregnant, So this topic is important. Now, so we are testing all of them, we are putting them on ARVs, but they are still not doing well. So something is definitely not right with our program right there, right? Now there is this particular report, and I was part of, because the sites that were evaluated were here in the district Ehlanzeni. This was a collaborative project with the MRC, our research council in the medical field, and they followed up women in the 3rd trimester and continued to follow them up postnatally up to 24 months. And all they were looking at was to look at the viral loads, and you'll see that we monitored 612 women, 71% of those were suppressed. But look at the rate, a proportion of pregnant women who had a detectable viral load more than 8,000. So testing women, putting them on ART is not good enough, right? In the context of women who are on ART and not suppressed. And there's still, this 13%, we don't talk about them. The women who are pregnant, HIV positive on ART, who have a viral load not more than 1,000 and not less than 50. She comes in, her viral load is 600 or 800. What we forget is that that particular viral load in a number of cases is significant, and it can still be transmitted to the next person. And that viral load can continue to replicate and cause harm. And you would see that the overall HIV transmission to the child was 1.7%, and then you look at new maternal HIV positivity. If you look at from the time the child, from 15 weeks to 6 months, postnatal, around 1% of women seroconverted, and just less than 0.5 women who are seroconverting. So we should not also forget women who are negative, either antenatally or postnatally, and the importance of retesting. And in this report, they talk about being young being a significant risk factor. And this report was done, the actual study was done pre-DTG. So at that time, the regimen at that point, your NNRTI, was also associated with women who are likely to fail and develop high viral loads. But for another day, we'll discuss why married people were at a higher risk of poor adherence. But the message really from this slide, linking up to this particular slide and this one, is that one, we are testing everyone. We are putting most women on ARVs. However, women are continuing to succumb to HIV complications in pregnancy. What is the problem is that even when they are on ART, a good proportion are not suppressed. Close to 30% of women have a detectable viral load that is replicating, destroying the CD4 counts, presenting with TB, PCP, and other HIV associated complications. Remember, a high viral load, yes, we have agreed that mothers don't do well, but a high viral load is equally associated with HIV transmission from the mother to their sexual partners, from the mother and also to the child. So this is quite important. And you'll see in this report, for viral loads less than 1,000, it seemed like transmissions are almost close to zero. But once your viral load crosses 1,000 to the higher side, you start to see an algorithmic increase in the number of HIV transmissions. The same study, they further looked deeper to say, well, we have seen in terms of more than 1,000 is clear. We know even our guidelines now are relying on a CD4 count cut point of 1,000 in terms of deciding when to intervene. But you would see that even at the viral loads less than 1,000, we still have significant HIV transmission in this context. So this is very important to know that an HIV viral load of 600 should not make us relax. We need to deal with that viral load in pregnancy, but as well during breastfeeding. So I hope you are still with me there. Lastly, where I see you guys, Nirusha, cousin, I'm happy that you were able to join. Zakira, Omar, welcome everyone. I will take hands at the end. Now, I looked at the number of publications really, and this is a summary of my understanding of what's going on. Number one, more than half of all pregnancies are not planned. This is from that survey. So if you have 5 women who fall pregnant, 10 women who fall pregnant, 5 of those pregnancies most likely were not planned. They didn't plan that they want to fall pregnant. So as we think about a viral load, I know we are talking about a viral load, but remember, a woman who does not know her status and she's positive, she's got a high viral load. So a high viral load in pregnancy is not just about women who are on ART. You should also remember that women who are HIV positive, who are not on ART, they are not failing treatment, but they have a high viral load at that point in time. So one of the things is to look at how we reduce the burden by increasing access to family planning, right? The second bullet there talks about the importance of women presenting early. And you'll see that in this particular report, only 1/3 of women presented in the first trimester. So most women, when they are pregnant, they present in the second trimester, and a good proportion as well in the third trimester. That means we are unable to initiate life-saving interventions, timely and save, our women. You would see in a different report, the Saving Mothers report, looking at women who succumbed to either HIV and other complications. 72% of women who died, had attended antenatal care, but however, more than half of these women presented in the third and second trimester. So our women are not presenting timely so that we can intervene. A different report again talks about the prevalence, of a viral load that was suppressed in this report was 85%. Remember, we expect 100% of women to be suppressed. And if you look at the global targets of 90, 95, 95, that means ultimately we want 95% of all women on earth to be suppressed. But if you compare 95 and 85, you realize that there's a huge, almost 10% gap in terms of where we are versus where we need to be. But also a high viral load is associated with bad obstetric outcomes. For example, in this particular report, which is also recent, a high viral load was associated with pregnancy loss. So we must have a 4D, appreciation of why we need to deal with a viral load, and we should have an allergy against a high viral load. If we see one, we must act on it. Also, the vast majority of women who died due to non-pregnancy related infections had attended antenatal care. Now, if antenatal care is seen as a prevention program where we are supposed to assess women, timely diagnose, timely start treatment, it means there's also quality issues around the provision of maternity services in the country. And we need to look into that. There's clinical issues, there's system issues, whether it's the lack of the right equipment, people not being trained, etc. But we have to respond to that as well, right? Now, in case you lose network today, before I get into some of the issues, this is my key message. So I start with a key message. My message to you today is the majority of pregnant women who are HIV positive, some of them die being on ARVs, right? 18% of HIV positive deaths were not on treatment, right? 73% were on a fixed dose combination. So we are now moving from a problem of testing and initiation of heart. The biggest problem we have today is treatment failure, is women who are HIV positive, who are on ART, who have a detectable viral load. And we need all of us to learn how to manage a high viral load in pregnancy, better, because if we do not, we are still going to have a lot of complications, HIV-associated complications, which we are failing to manage. So in terms of that last part, learning how to manage better, let's get into it. So here's a scenario, a 34-year-old Tando who comes to you. So firstly, he presented initially antenatally during her first visit. She was 5 weeks. She wanted to be tested. She was tested, then she tested positive. You see that she was initiated on tenofovir, emtricitabine, and efavirenz. During that time, the baseline CD4 count was 250 cells. She had a creatinine of 90. The gene expert was negative during the initiation. Today, you see her for her 3 months evaluation or follow-up, and she has no complaints, but she tells you that she started TB treatment about a month ago. She reports good adherence and she's okay, So we start there, we start from the basics. If a woman presents like Tando, she's no complaints, she's HIV positive, she's got pulmonary TB on treatment for at least a month, what would be her appropriate WHO staging? So I will give you, we will take a maximum of 30 seconds per poll. And then after that, I'll be forced to pause so that we can engage on that particular scenario. Feel free to participate. These polls are anonymous. We can never know what you selected, but it's for learning purposes. So it's exactly 30 seconds. I'm going to stop. Don't worry if you didn't manage, it's okay. So I see that most of you are saying WHO stage 3, and that is correct. So remember that a pulmonary TB, a basic pulmonary TB is a stage 3 condition. Extra pulmonary TB is a stage 4 condition. When we say stage 1, we are talking about patients who are asymptomatic. So they are positive, but they are well and healthy, most of them. Stage 2, they start to present with skin conditions, herpes zoster, herpes simplex, fungal infections, but they start to lose weight, less than 10% of their body weight. Stage 3, they are becoming very sick. They have severe bacterial infections, pulmonary TB, bacterial pneumonia, bacterial meningitis, oral candida, for example. And then stage 4, we are talking about someone who's very sick. They've got AIDS-defining conditions like invasive cancer of the cervix, cryptococcal meningitis, PCP pneumonia, so specific, pneumonias that are very bad, contributing to significant morbidity, HIV wasting, where a patient has lost both fat and the lean body mass. So just remember, staging, don't complicate it. Stage 1, asymptomatic. Stage 2, if you use candida, limited to the corners of the mouth, which is angular cheilitis. Oral candida, stage 3. Esophageal candida, stage 4. So very, 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 very important. Now, if you see a pregnant mom during a 3 months visit, right, what are the assessments that need to be done? And I'm using South African guidelines from government, but I will also mention some of the things there and there about the private sector. But if you see Thando today, she's stable, no complaints, she came because it's a scheduled visit. Which of the following, you may choose more than one option. Which of the following would be some of the key assessments you would do during a 3 months follow-up of an HIV positive pregnant mom? All right, 10 more seconds and then I will stop and then we will engage on this particular scenario. Okay, I'm going to stop. I'm hoping we'll have enough time for more scenarios towards the end by God's grace. So yes, a creatinine, remember it's done at baseline when you start the ARVs. If it comes back normal, we repeat it in 3 months time. A viral load in pregnancy, I'm gonna show you now. There's 2 kinds of women, but for a woman like Thando, who was initiated for the first time on ARVs during the current pregnancy, she would be eligible for a viral load 3 months after the date when she was started on ARVs. So she's 3 months on ARVs, she's due for a viral load. Basic antenatal care, all visits we have to integrate and ensure that she's not bleeding, there's no anemia, there's no hypertension, the comprehensive assessment of women. A CD4 count, unfortunately not. We only do a CD4 count at baseline when you start ARVs, and then again when your patient is 12 months on ARVs. In this scenario, she was started already 3 months ago, so there's no indication for a CD4 count, and we have the baseline CD4 count, which was 250. So I hope you have managed to follow there. Now, basic antenatal care and the importance of integration between HIV care and maternal child health services cannot be, overemphasized. It's important that whenever you see a pregnant mom, you provide comprehensive care with a plan to assess, identify risk factors and ensure that women who have particular risks are then referred and are seen at high-risk clinics at different levels of the health system, depending on what the issue is. And if she's stable, it's routine care, like we are seeing our case scenario today. We don't need to refer her, but we must do a comprehensive assessment. So that is very important. Some of the assessments, we have to assess if she's experiencing side effects. She's already on TB treatment, so we don't need to be screening again. We have to support her to ensure that she's adherent, discuss issues of safe sex with the sexual partners, and some of these, even for HIV negative women, they're important because some women would seroconvert, moving from a negative HIV status to a positive HIV status during pregnancy, which is something we really, don't want. The WHO staging must be done, your MOACs, your BMIs, they must be done. Hepatitis B only at baseline. A viral load, you see, I put a red dot there to remind you that a woman who started ARVs for the first time during a particular pregnancy, 3 months down the line, a viral load must be done, right? So don't forget that. And then I'll still discuss the schedule for virological testing shortly. If she was taking a zidovudine-based regimen, we would do an HB. If she's taking a tenofovir-based regimen, that's why we are doing a creatinine test, because we want to see once your creatinine goes up above 85, we have to be cautious about using TDF, and where possible, we should avoid its use. Your ALT for nevirapine and your fasting cholesterol if they are taking lopinavir, ritonavir. So if you look at our scenario, the patient is on tenofovir, lamivudine, and efavirenz. So really, the only test we need to do is a creatinine clearance. We need to do a 3 months viral load. There is no need to do a CD4 count. Pap smear can always be done 6 weeks postnatal. Hepatitis B should have been done at baseline, and all these others are soft things that we need to do. So I hope you are with me there. So this is the testing protocol, particularly for the viral load in pregnancy, right? Number one, if you have a woman who is newly diagnosed HIV positive during, so she becomes pregnant during your booking visit, you do an HIV test and she tests positive for the first time during the current pregnancy, your priority is to start her on ARVs, right? Then help her to adhere for the next 3 months. When she's 3 months on ARVs, we then do our first viral load. Remember, in non-pregnant adults, the first viral load would have been at 6 months, right, on Earth. So now in our context, we start ARVs first for 3 months, then we do that particular viral load. And if it is suppressed, the next viral load is a delivery viral load. A delivery viral load is mandatory for all HIV positive women on Earth. When after they deliver, we do a viral load, and we'll talk about that further. Now, sometimes you have a woman who knows her status. She's already on ARVs, so she falls pregnant whilst on ARVs. What do? During the day when you diagnose the pregnancy, right? She's been taking ARVs in the adult program, she falls pregnant. The day the pregnancy is diagnosed, we must do a viral load, right? So please do differentiate between these two women. And if the viral load is suppressed, we do it again at delivery there. Now, here's a complicated, and I think we had a case even today. I got a call about a pregnant mom who has defaulted, what do we do, So if she's a known HIV positive, so she's a known positive, but currently not on ART. And most of the time, these are exposed patients who had been on another regimen, they default, they come in today, she's pregnant. When you ask about testing, she says, no, I know my status. I was taking those drugs a year ago. So what do you do then in that situation? So firstly, you initiate her the PMTCT program compared to the adult program. The adult program would have said, start her on her old regimen, do the viral load after 3 months, and then, decide if it's working or not. But in pregnancy, we don't have time. So the recommendation is that she should be started on a dolutegravir-based regimen, and you must repeat your viral load in 3 months' time. If that viral load is suppressed, then we do it again at delivery. If the viral load is high, then we are in trouble. We need to deal with it right there, right? But please remember the switching of the drugs, and I hope Mr. Walter is here because he also called me about a similar case, and I said, Walter, we may switch, but remember, switching does not address social problems and reasons why your patient has defaulted in the first place. So we should always remember that component, that we need to deal with the reasons behind the defaulting. That is quite important. So it's a very busy slide. I took it exactly from the guidelines, as it is, but you'll see that it's a newly initiated on ART during the current pregnancy. You start ARVs the day you see her. In 3 months' time, you do your viral load. If it is suppressed, we repeat it again at delivery. If it is high, you follow the algorithm for women who present with high viral loads in pregnancy who are on ART. If she's already on ARVs at the time when she falls pregnant, during the pregnancy diagnosis, we have to do a viral load. And if the viral load is suppressed, the next one will be done at delivery. Remember, postnatally, we do the viral loads every 6 months until 24 months. So it will be a delivery viral load 6 months, 12 months, 18 months, 24 months. And then if she's still suppressed at 24 months and the baby's PCR is still remaining negative, they are discharged to the adult and pediatric program. And that's how we want to deal with it. So I hope this summarizes it very nicely. It will be crime for me to talk about a viral load and not talk about system issues that may affect your results. So in South Africa, we have a gatekeeping mechanism. It's meant to minimize the abuse of the testing and doing viral loads as and when. So in order for your viral load to be done by the lab, because remember, there's a standard protocol in the adult program that if someone is started on ART, the next viral load is at 6 months. But in pregnancy, for example, you would do it at 3 months. So how does the lab know whether to reject or not to reject that viral load? You have to write down. I'm talking to the public sector, right? If you're in private, probably you don't use this code. So in the public sector, if this is an antenatal viral load, you will use C hashtag PMTCT. And I think I'll ask one of the colleagues, as Dobza, if you are here, to comment on this later on. But you'll see that C hashtag PMTCT is used during pregnancy and breastfeeding. And then C hashtag delivery is particular for that delivery viral load so that it can be allocated appropriately, for your patient. And you need to put it, this is an example of the lab form where they say, please, your GK approved code there, you put C hashtag PMTCT. Therefore, the lab is able to accept a viral load outside of the normal adult program viral load testing. Even if your form does not have that space, maybe you're using the old form, it's okay. Just put the code and then the lab technicians have to capture it, and then it is likely to be approved and the test would be done. So this is a system issue which may impact on whether the viral load is done. And remember, delays in getting the results have significant impact on how you further manage your patient or even the child. You saw that our case scenario, the patient was initiated on TEE. I don't know the reason for that, right? We still have a lot of health workers who are cautious for one reason or the other. And during the month of May, we are going to have a topic just focusing on TLD and TEE, when to use which one and why, But in an ideal situation, she was supposed to have been initiated on TLD because it is based on dolutegravir, which is known to be a very potent drug, well-tolerated, fewer side effects, high barrier to resistance. And later on, when she needs her contraception, there are no significant drug-drug interactions really, between DTG and your family planning drugs. Obviously, you have to monitor drug-drug interactions because DTG with calcium, iron, your aluminum, magnesium, your anti-acids can really reduce the effectiveness of the drug. And there's an issue about weight gain. And I think we will have a specific topic really to discuss this weight gain. How does it happen? And what is it that we need to be doing? But lifestyle modification is the order of the day, right? So remember, TLD would have been best. The patient was started on TEE and then developed TB treatment. So on the positive side is that efavirenz does not have any significant interactions with rifampicin. So by God's grace, things are going well. So we support that and we keep it at that level there. So in our context of a patient who started on an efavirenz-based regimen and develops TB, started on a rifampicin-based TB regimen. With efavirenz, no dose adjustments are necessary, right? If the patient was taking DTG, she would have been started on 50 milligrams per os BD, right? NRTIs, tenofovir, abacavir, zidovudin, and so on, they are generally metabolized through the renal system. There's no need to do any dose adjustments. Nevirapine should never be given with TB treatment. And lopinavir, ritonavir, generally, you either double the dose or prescribe additional ritonavir as a boosting a mechanism to minimize, the effect on lopinavir, where the blood levels would be lowered. So remember, the theory behind it is that rifampicin is a liver enzyme inducer, so it increases the metabolism of certain drugs, therefore reducing their effectiveness, and your patient may fail ARVs. Which are those drugs? Dolutegravir, nevirapine, lopinavir, ritonavir. Nevirapine, never give with TB treatment. Dolutegravir, increase the dose from 50 milligrams daily to 12 hourly. Efavirenz, continue as prescribed. Lopinavir, you need to increase the dose by either doubling the dose or prescribing additional ritonavir on the side. Then you win. So I hope, up to here, you are with me and you are still engaged. Do try and type in your comments on the Q&A session. I see there Nomalanga Goratha, you are saying, thank you for this presentation. Yeah, I hope you are enjoying it. Says Nomsa, you are saying this is the 2019, actually the green book, the consolidated HIV guidelines for managing children, adults, and pregnant women. It's actually 2020, so I'm replying. I think I saw Dr. Nzimande, you are asking which guideline is this. So yeah, so the HIV space can move very quickly. But luckily you are joining today, and I think the platform is achieving its mission, which is to keep you updated. Now, Tando is bringing problems now, isn't it? So you did have 3 months creatinine, which is 70, so it's acceptable. Her viral load is 10,000 copies. She's still on TB treatment. She reports good adherence, and she says, hey, Mina, I've never missed any tablets. So you are like, okay, what's going on? So if you see a patient who is pregnant, who presents with a detectable viral load of more than 10,000 copies, and it's your first high viral load, which of these options would you opt for? I know there's other things, you might type them, but just for discussion, you may choose more than one option there. What would be the best steps for you to take? Thanks. Hey, this topic, Shem, I've never finished it in an hour, so you'll forgive me. We might run over a bit. We're supposed to be 1 hour, 30 minutes, but yeah, as long as you grab something out of this, it's perfect. All right, it's exactly 30 seconds. I'm going to stop and then show you. So yes, enhanced adherence counseling. So it's a problem-solving exercise, working with the patient, trying to understand why is your viral load high. Repeat the viral load in 3 months. Repeat the viral load in 1 month. Yep, right? So in pregnancy, see, so for a non-pregnant adult, we would have 3 months for suppression. In pregnancy, you have 30 days. You have 1 month to work with your mother, the pregnant mom, to suppression, right? Switch efavirenz to DTG, that would be a crime because your patient has a detectable viral load, right? What we don't want to do is to rush into making single drug switches, right? I know that current studies somewhere show that the DTG would still do the work, but let's stick to the public guidelines in terms of this presentation and say a single drug substitution is not ideal, and besides, it's too early. You have only 1 high viral load. Switch to second line, it's too early. It's too early. Yes, she's pregnant. We are in a hurry. That the whole time is there. He was telling me, no, but she's pregnant, doctor. I said, but we need to give her at least 4 weeks, and see if she can't resuppress. So enhanced adherence counseling, seeing this woman weekly for the next 4 weeks, or at least twice in these 4 weeks, bringing in a treatment supporter, dealing with whatever challenges she has, is what we are going to do for 4 weeks, 1 month, 30 days. Then we repeat the viral load and see if we are going to have progress right there. So when a viral load, so it's a very busy slide from the guidelines, right? You'll see, but I'll help you to see it. It says here, non-suppression. So if you've got a pregnant mom who's got a detectable viral load, right? And in our instance, the viral load is 10,000. So it's more than 1,000 copies. It says here, you need to do enhance that red arrow there, A, B, C, D, E, working with the mother, trying to figure out where are the issues. Are you forgetting to take your tablets? Do you have support? Have you disclosed to someone? Are you being abused by substances? Are you a mental health user? And so on. Does she currently have infections that we need to treat? Is she taking the drugs correctly? Are the drug interactions, like I said, rifampicin, but luckily she's on efavirenz, so we don't think there's going to be issues. Is she taking other medicines at home, traditional things that may make ARVs to be less effective? Is there an indication for a resistance test? So you'll go through A, B, C, D, E with the mother, repeat the viral load in 4 weeks time, right? 4 weeks is the target. But the 6 weeks, it has to do with the timing. So sometimes postnatally, for example, you might want to say, no, come back when you bring the child for immunization. So 4 weeks is the target. 6 weeks is like the maximum timeline between the two viral loads, right? Now, look at this very carefully. And I need you to understand this particular part here, right? So it says here, the viral load is 10,000. That's what we are evaluating now. We do the A, B, C, D, E. We repeat it again in 4 weeks time. After 4 weeks, when we repeat the second viral load, we have to decide. If the viral load is still significantly high, right? So it means you've got 2 consecutive viral loads, viral load 1, viral load 2, more than 1,000 after intense adherence support, you should probably consider that the mother has failed ARVs and she needs a better regimen. So that is the first wing. The part that I need you to pay attention to is this part here. It says here, if the first viral load is 10,000, as is the case, right? And we repeat it in 4 weeks time, but there is more than 1 log drop. So what is this 1 log drop from mathematics? It's a 10th. Basically, you lose a 0. So a 1,000 becomes 100. So let's say the viral load is 8,000, and after 4 weeks, it is 800. So from 1,000 to 800, it's 1 log drop. You have lost a 10th. From 100,000 to tens of thousands. From a million to 100,000, right? Remember, a million has 6 zeros. 100,000 has 5 zeros. So they would have lost a 0 or a log. And I will show you now. Now, in the case where a log has been lost, we then give our patient some time, for recovery, and we may repeat the viral load in 2 months' time. So where there's more than 1 log drop, we generally do not we don't become in a hurry to switch our patients. We then just give them a little bit more time. So this is quite important right there, right? So are you understanding the log story? Please tell me if you need me to clarify the log story again. You can type in the chat box and say, hi, doctor, please repeat there, and then I will try my best to repeat. Right, let me see. Seems like we are all okay with the log. So it's a 10th. No, you are losing a 0. So I'm very happy with what I see. I don't know what happened to my slides. Few seconds. I might have messed up something. Oh, yes. No. I think it's perfect. Sorry about that. Yes. So evaluation of a patient with a high viral load, don't be judgmental. Don't fight with the patient. Be supportive, right? Make sure that you have tools in your clinic to assess adherence so that you are able to help, your patient. Remember, the reasons for a high viral load are multifactorial. The simple things like you tracking viral loads over time, making sure that your patients are picking up their medicines, talking to your team and helping your patients to disclose so that they can have support at home. There's clinical factors around our own prescribing habits, drug-drug interactions, the mental state of your patient, substance abuse. But equally, there's the socio-economic issues. People are hungry, they're unemployed, they don't have money to come to the clinic. So it's not always the patient's fault. So you have to really take that into account. So here's our patient is back. Tando returns for her second viral load result, right? And she says, I'm still adherent, I'm okay, and there you are. So you've got your first viral load, which is 10,000 copies. You've got your second viral load, which is 9.5 copies, and the hepatitis B status is negative. And then also as well, the HB is 11.1. So in the context of a viral load, that shifts basically from, 10,000 to 9.5. It has dropped. What is your plan? How would you further manage Tando at that point in time? The HB is okay. There are no other issues with our case scenario. How would you manage her? Okay, 10 more seconds. All right, great. That is good. Let's all try to participate and at least give it a chance so that I can see exactly what is it that you want to do. All right. Okay, interesting. Let me stop and show you the results. One says continue current regimen. I will. And that's why I wanted more and more people to vote, because it's a tie of some sort, between are we continuing or are we switching? It seems like, yeah, okay. Where we are agreeing is that we must provide enhanced adherence support. Repeat the viral load, switch one drug. Okay, so let's deal with the easy part. We can't switch one drug because we have 2 consecutive viral loads that are more than 1,000. So we can't play. We need to decide what to do. But if you're saying switch, it might still mean second line if you're thinking of the new reports on the Nadia study. But, sticking to the guidelines, we won't do a single drug switch. We won't repeat the viral load. Yeah, there's a possibility to repeat, but not really, So my sense is that we can't continue the regimen. She's pregnant. We are running out of time. We need to try and give her the best possible regimen we can give her, and then still deal with any adherence issues that we need to deal with. But let's see what the team that was dealing with this case then opted to do. So what is treatment failure in pregnancy? An important definition: 2 consecutive viral loads more than 1,000 taken 1 month apart. So that's where the issue starts, 2 consecutive viral loads 1 month apart in pregnancy. For a mom who has taken ARVs for more than 3 months, she has failed, right? I think the challenge with the case is this log thing. And unfortunately, we don't have the logs, but I can tell you now that a change from 10,000, even though it seems like there's a zero missing, right? But I can tell you from 10,000 to 9.5, it's not a full log. It's not a full log. And I'm going to show you examples now, and you'll see why am I saying this. So basically, we've got 2 consecutive viral loads more than 1,000. We should consider switching, but there's a concern that maybe she improved by more than 1 log, but I can tell you, not from 10,000 to 9.5. There's a drop, but it's less than 1. It might be a 0 point something of a log. Let's look at how these logs work, and you'll see here. This is an obvious one. The first viral load is 430 something thousand, and it's 5.6 logs, right? Then after adherence, we have a second viral load, which is 9,550, and it's 3.9. So in your lab results, they will have given you the first log and the second log. All you need to do is to say 5.6 minus 3.9. If your answer is more than 1, then you say, no, this patient, I'm going to give more adherence and repeat the viral load in 2 months' time. So tell me, in this particular scenario, this one of these 2 logs, will you switch this patient to second line or not? This patient who presents with these 2 viral loads. Yeah, the logs, I can tell you, every time I teach logs, I work on how best do I teach it, because all right, so let me show you your results, and you'll see why I'm moaning about the logs. So you'll see that 60% are saying no, I'm not switching, and the answer is no. Why are we saying no, we are not switching? Is because if you say 5.6 minus 3.9, you're going to get 1.5. Let's say you get 1.5. 1.5 is more than 1. Let me take you back to the algorithm there. Sorry, I don't know how to go back. Yes, remember the algorithm says when you compare the first viral load and the second viral load, particularly the logs, and there is more than 1 log drop, you are not switching to second line, right? You are monitoring your patient for 2 months, 8 weeks, right? 8 weeks exactly, and then you repeat the viral load. So that is the story. So in this scenario, when you say first log minus second log, we get 1 point something. So it's more than 1. You are not switching this patient to second line. You are doing adherence, repeat the viral load in 2 months' time. This is a different scenario. The first logs is 5.9. The second log is 4.4. And I'm going to ask you the same question. Will you switch this patient to second line or not? There is more than 1 log drop. As for the logs, I don't know. I'm gonna ask someone to teach it. Somebody who's got who can explain it better than I do. But just take 5.9 minus 4.4, it will give you 1.4. It's more than 1. You can't switch this patient to second line. So the correct answer is no, you are not switching this patient, because yes, the 2 viral loads are more than 1,000, but there was an improvement. There was at least 1 log drop. 5.9 minus 4.4 is 1 point something. Use your calculator. If you get 0 point something, switch to second line. If you get 1 point something or 2 or 3, then you are not switching your patient. Hey, okay. Here's another one. It's 127,000. It's 88,000. Yes, these 2 viral loads are more than 1,000. But the first log is 5.1. The second log is 4.9. Take your calculator now where you are. Take your calculator. Say 5.1 minus 4.9. What are you going to get? Can somebody help me? You're going to get a number less than 1. It's going to be a 0 point something. So there was no improvement. There was no 1 log improvement. Are you going to switch this patient to second line? Please make me happy. Otherwise, I come back. I teach again next week, the same topic. All right. Yeah, this is better. You know, 90% of you said this time we are switching the patient to second line. Why? Because we have 2 consecutive viral loads more than 1,000, and there was no log improvement, right? The improvement was less than 1. If you say 5.1 minus 4.9, you get 0 point something. So yes, but I still need to convince that 10% that said no. So, okay. Yes, this is the last one. This is the last one, right? So the 5,000 and 1,000, right? And this is in our case, our real case, the 10,000 versus the 9.5. This is the kind of logs we are going to find, that there is some log drop, but it is not enough. It is not enough. 3.7 to 3.2. If you minus 3.2 from 3.7, you're going to get 0.5. 0.5, is it more than 1 or less than 1? It is less than 1. Therefore, there is no improvement in the logs. If there is no improvement in the logs, do we switch to second line, yes or no? The answer is yes. We are going to switch to second line. Please don't click on no. All right. Hey, it's the logs there. I don't know why we had to add bets to PMTCT. I hope the national guys are here attending so that they can help us. So I'm happy with this answer, 99.9%, but I was hoping for 100%, but I think I will accept 99% said we are switching our patient, right? I hope it's a great learning exercise as well. Now, in terms of switching this woman, remember, she's currently taking an efavirenz-based regimen. Once we have confirmed the logs, and in my view, there is no log improvement, she needs to be switched, we would then opt to switch her to a dolutegravir-based regimen unless there is absolute contraindications to the use of DTG, then we can give lopinavir or atazanavir, right? So if you look at our guidelines, any patient who fails, this is first line. Remember, she's on first line. She's taking tenofovir, emtricitabine, efavirenz. This is where we are. This is her regimen. There is no need for us to do a resistance test. We've got 2 viral loads, more than 1,000. There is no log drop. And remember, her hepatitis B was negative. So just follow the guidelines. Stop tenofovir, give zidovudine, continue lamivudine, stop efavirenz, and give DTG. So we follow the guidelines. But I know that the guidelines are likely to be updated based on the new data from the Nadia study and many other studies. But let's not talk about and confuse, everyone. Let's stick to this table copied and pasted here from the guidelines. The best regimen for our case scenario is a combination of zidovudine, lamivudine, and dolutegravir. So that is our standard second line regimen for most patients who are going to fail what we call TEE, tenofovir, emtricitabine, and efavirenz there. So if you look at the actual regimen, it will be zidovudine there, 300 milligrams per os BD. Please monitor the HB together with lamivudine, 300 milligrams daily, right? And if you give the fixed dose combination, these 2 drugs, there is a fixed dose combination. It's called Lamzit. So it will be, then it will have the 300 and the 150 taken BD so that your patient doesn't take a lot of tablets, right? So Lamzit, 1 tablet BD plus dolutegravir, 50 milligrams per os daily, right? And then this sentence is important. It is dolutegravir is recommended for all women, irrespective of fertility plans or pregnancy duration. First trimester, second trimester, third trimester, DTG. Pregnant or not pregnant, DTG. Planning to fall pregnant or planning not to fall pregnant, DTG. So things have changed, and we will have that topic on the 17th of May there. Remember, don't forget other things, issues of adherence, to continue to monitor the viral load after you have switched her, TB screening, help her to decide on the feeding option. Hopefully it's breastfeeding and we are able to support her. Discuss future family planning, a pap smear postnatally, and ensure that nutritionally the mother, is supported. So her second viral load was 9.5. She was given zidovudine, lamivudine, and dolutegravir 50 milligrams BD when she was 4 months pregnant. Do you see that one? So don't forget, she was on TB treatment. Remember, on TB treatment there. So we needed to increase the dolutegravir to 50 milligrams BD. This was a month later. She came in when she was 3 months. So at 4 months, that's the regimen she started. And she's now, when you see her now, she has completed TB treatment when she was 8 months. Now I have a nice question for you. Remember, DTG here was increased from 50 milligrams daily to 50 milligrams BD because she was on TB treatment. But now she has completed TB treatment. When do we take DTG back to the normal dose? When? What is the correct timing for that? If you have a patient who completes TB treatment today and they're taking DTG BD, when are you going to put it back to a daily dose? This one, and it's in the guideline. I wish I had copied it to show you the answer. Anyway, unfortunately for this one, I'm going to stop. I see you are still voting. Okay, 5 more seconds, but the way it's going, I can see it. All right, what does the guideline say? So for the first time today, majority does not rule, right? If you chose 2 weeks, you have chosen the best answer based on what is in our guidelines. So if someone completes TB treatment today, you continue with your boosted dose for at least 2 weeks. This is because it takes about 2 weeks, firstly for the enzymes to be revved up when you start rifampicin, but also for the enzymes to go back to their normal functioning when you stop rifampicin. So 2 weeks is the correct answer. I thought I should ask you that and give you information around it. Now, when is she due for the next viral load? She's already 9 months pregnant or something, right? So when was she due? By the time, yeah, but just tell me, when was she due for the next viral load? It will be a very interesting discussion. If this we were in class, we were going to argue about it. Yeah, we can argue. I see where this is going. Great stuff. Very, very, very interesting. I wonder what the experts are choosing. All right. So I'm going to stop and then show you. So there's 2 competing points, right? And I want to explain this carefully so that you understand what we are trying to do. Firstly, remember the schedule for her as someone who was diagnosed during the current pregnancy. She would have been done 3 months after she started ARVs. Unfortunately, that 3 months viral load came back up. Then we repeated it in 4 months' time. It was up, and then we switched her. So don't forget that she was switched, right? So there's two answers, basically. You do it at 3 months or at delivery, whichever one comes first. Are we together? If you switch a pregnant woman to second line, you need to know the monitoring and ensure that you want to know whether she's now suppressing or what's going on, right? And on DTG, 3 months is even far. We could have done it earlier, but 3 months in pregnancy is acceptable. So if you look at the fact that she was put on DTG when she was 4 months pregnant, it means when she was 7 months pregnant, which would have been 3 months from that time, we were supposed to have done a viral load. A delivery viral load would be done anyway because that is a program viral load and it must be done. But the monitoring of patients who are pregnant after you switch them to second line, ideally you want to do that 3 months viral load because switching to a new regimen is the same as initiating on a new regimen, and we need to know that she is suppressed. We don't want to delay it longer than that. But a delivery viral load, you can never go wrong, but I think we could still do it earlier. So here's a follow-up scenario. Baby Lesego, that is me, he's born, and then unfortunately, you don't have the repeat viral load results. You don't have the 7 months, you don't have the delivery results for the baby. How would you approach this infant? I can tell you this is the last polling for the night. If how would you manage the infant? Let's say when it's me, please manage me properly. So it's by name, you know. So yeah, you know, she's been on DTG, the mother, for 5 months. You did a delivery viral load, you don't have the results. We could have done it earlier, but it was not done. So yeah, you know, and you can choose more than one answer. All right. Yeah, please forgive me. Today we will go a little bit beyond time, but I hope it's worth your time as well. All right, I pause and then we do a quick discussion. So number one, and we'll discuss some important principles, right? So the majority, you said nevirapine and AZT, you'll do a PCR today, you'll do a PCR at 10 weeks, you'll start cotrimoxazole. So let's start with the easy stuff. Cotrimoxazole for infants who are born from HIV positive mothers, so these we call HIV exposed infants. It started not at birth, right? It started at 6 weeks. So once the child turns 6 weeks, during the 6 weeks immunization, we will start cotrimoxazole. So that's a tick. We can never defer. A 10-week PCR must be done, but that doesn't mean we defer the birth PCR. So we do a PCR today, right? And then we'll still do a 10 weeks one when 10 weeks come. So we will do a PCR. We will start cotrimoxazole not today at 6 weeks. Now the last question, do we start 6 weeks nevirapine or AZT and nevirapine? And in the guidelines, it is stated very, very easily that all babies, all must be started on high-risk prophylaxis until you can confirm that the mother is suppressed. Now, I want to ask you a question. Do you think this mother is suppressed? You are assuming, but you don't have any recent viral load that shows suppression. Therefore, this infant will be started on nevirapine and AZT until you get your viral load results. If that result, the birth delivery viral load comes back suppressed, that's when you can decide to stop AZT and only give nevirapine for 6 weeks. I hope that is clear. So if you are in labor ward today, there's a child who's born from an HIV positive mom on earth, and you don't have a recent viral load that shows that the mother is suppressed, right? You start all babies on nevirapine and AZT, you track your delivery viral load, you only change or adjust the regimen once you have a confirmation that the mother is suppressed. That's how we manage them. So here, the key interventions are nevirapine and AZT. Start today and do a PCR today. All the other things are not indicated. So I hope you are with me. Yeah, so we are nearing the end in terms of the theoretical component. To mention that PMTCT has 2 strategies in terms of preventing transmission to the child now, right? Number one, we want to get the mother to be suppressed as soon as possible. Number two, we want to ensure that the child gets appropriate infant prophylaxis, you know, like a post-exposure prophylaxis. And the way I've explained it, all babies, you start them on nevirapine and AZT, you then adjust once you get your confirmation that the viral load is suppressed. Immediately after they are born at birth, you want to do your PCR because we want to identify babies who would have been infected intrauterine, right? Cotrimoxazole will be started at 6 weeks. We protect and promote breastfeeding even in this context. And how do we protect the breastfeeding? By ensuring that mothers are suppressed. We encourage exclusive breastfeeding, and we provide prophylaxis, high-risk prophylaxis for all babies where we feel that the mother is not suppressed. And we have to integrate with your immunization programs, ensure that these babies are growing, you know, well, neurodevelopment is also happening the way it should. So that is very key and important. So once you get your viral load result and the mother is suppressed, you classify the mother-baby pair as low risk. Therefore, they can just take nevirapine for 6 weeks, and that is fine. However, if there's still some viral load or the mother, you saw her for the first time in labor, she was not suppressed, or she's a defaulter, you know, all sorts of things. She tests positive for the first time during breastfeeding. Put the child on dual prophylaxis whilst you deal with the mother, putting her on ART until she is suppressed. I have a golden rule, and I call it never leave the infant unprotected. You should never find a situation where you have stopped the prophylaxis and the mother is not suppressed. Now you have left the child exposed, right? If the mother is suppressed, you can stop the prophylaxis. If the mother is not suppressed, the child should always be on the prophylaxis. And really, that is my message to you. So early infant diagnosis, PCR at birth. If it's negative, we do it again at 10 weeks. If it's negative, we do it again at 6 months. If it's negative, all HIV-exposed infants at 18 months who are not on ART, don't go and test babies who are on ARVs because you'll get complications, and don't call me. But 18 months, we do a rapid test, right? And then anytime the mother stopped breastfeeding, you can test the child 6 weeks after breastfeeding has been stopped to make sure that the child is truly negative. Anytime the child is sick, so yes, there's a schedule. Let's say you see a 3-week-old infant who's got failure to thrive, diarrhea, loss of weight. Please don't say I'm waiting for 10 weeks to do a PCR. No, you are allowed to do a PCR anytime you are dealing with a sick child. In other words, all babies who are admitted in the pediatric ward should have a PCR done if they are HIV exposed. That is the golden rule. And then the exit test, and we are hoping this confirmatory rapid test at 2 years is negative, and we celebrate with the parents and say, yeah, we have won. Your child is an HIV-free infant. Just to always remind you that HIV-exposed infants are high risk of poor birth outcomes, complications, poor growth, hospitalization, and mainly because their mothers tend to be sick, they tend to die as well, you know. So an HIV-exposed, that means a child born from an HIV-positive mom, where the child's final HIV status has not yet been confirmed. That means the child is less than 2 years of age. We need to monitor those babies closely and make sure that they are growing well, they are remaining negative, they are being fed well, you know, and then that is the ultimate goal. Cotrimoxazole in infants started at 6 weeks. Continue for as long as the child is being breastfed. Cotrimoxazole should never be stopped, right? You'll stop it 2 to 4 weeks after breastfeeding has been stopped. Ideally, when you get your negative PCR results, that's when you stop cotrimoxazole. Ensure that they are growing well, breastfeeding is best, you know, make sure immunizations are okay. Don't forget the mother, you know, this slide of mine. If you see the baby, ask, let's say it's an EPI visit for immunization, ask, where is the mother? How is she doing? Is she okay? Is she on ARVs? Have we done a pap smear, you know? If a mother comes in, she's in the sexual, in the reproductive age, ask, do you have kids? How many are they? Have they been tested? Are they on ARVs or what's going on? So have an interest, because kids don't do well without their mothers. And a mother who's got kids who are not well is an unhappy mother, and we don't want an unhappy world. So as I summarize today's session, I go back to my key message to you. The majority of pregnant women in our country have been tested. They are on ARVs. However, they continue to succumb to HIV-related complications in pregnancy. Why? Because there's an issue of the effectiveness of the treatment. The majority are failing treatment. So yes, we must continue to enhance testing, to enhance our starting, but we have to master the process, the magic of keeping women suppressed. And we have to work on retention, ensuring that women are supported, disclosure programs, and so on. And I've tried to put this today. I worked on saying, if I was the minister, what would I advise the program? Well, I would say, what is the life cycle of a sexual and reproductive health life cycle of a woman? So there's things we need to do in the pre-pregnancy before she doesn't even want to be pregnant. She's just there working. We need to ensure that women are empowered. We deal with literacy, increasing access to education, ensuring that women, they are empowered, they're able to negotiate, when to have sex, unprotected sex. There's no power dynamics in relationships. We have to optimize access to sexual and reproductive health services. Ensure that these services, you can't point at them. They are so integrated in what we do. And our services are youth friendly, so that this age group, 15 and 24, can really access our services on time. PrEP, because if we find an HIV negative young girl, we put her on PrEP, she's likely to stay there. Long-term or long-acting family planning, and then optimize ART treatment for now. There's a population of women who are living with HIV coming to our clinics collecting drugs on a monthly basis, and they're in their sexual reproductive age. We need to find ways to ensure that the adult ART program is tracking all women who have a detectable viral load, and we ensure that they are suppressed, so that the day they fall pregnant suppressed, not what we are seeing currently. If you do get a chance and someone is interested to fall pregnant, you have to optimize their health, provide HIV testing. If they are positive, ensure that they are suppressed before they fall pregnant, and ensure that you include me, the man, and the family in supporting the woman, because she's planning to fall pregnant. The journey is too long. Early in pregnancy, universal pregnancy testing. All women, if today you are on call and you're going to see any woman in the sexual reproductive age, you must provide a pregnancy test, because it's national protocol. If you want the protocol, ask me, I'll send it to you. It's a signed off memo nationally that all women, for any consult, she's got a headache or broken leg, provide a pregnancy test. And if the test is positive, same day, ANC booking. We don't say come back Thursday, we have pregnancy days. There's no pregnancy days in South Africa. There's just healthcare. And if a woman is seen in casualty and she's pregnant, you need to book her and ensure that she's got an antenatal card, and basic things have been done, including an HIV test. And if it's positive, ART is started before she leaves the hospital. We need to ensure that we do community engagement so that women can present early when they are pregnant. Ensure that ART is started early and opportunistic infections are treated, and we exclude TB. Once she's in the antenatal care, me and you, we have to know what we are doing. We can't be clinicians in South Africa where there's a high HIV burden, and we are found nowhere when it comes to these clinical guidelines and what needs to be done. And remember, a woman who's tested when she's pregnant and she tests positive, negative, right? So if my wife was pregnant and she tests negative, she must get PrEP. It's a protocol. It's in the PrEP guidelines. It's in the PMTCT guidelines. HIV negative women who are pregnant must receive PrEP. There's no risk for anything there. And then if she's positive, we want to get the viral load to be suppressed. You want a confirmation that she is suppressed, and we must support the mothers. It's too much to take this whole program. Labor and delivery, all women who present in labor, 5 centimeters dilated, 10 centimeters dilated, we have to offer an HIV test. If it's positive, provide the right interventions and ensure that she's discharged on ARVs. This is very, very, very key, and avoid invasive procedures. Immediately after delivery viral load, appropriate infant prophylaxis, high risk until confirmed low risk, provide long-acting family planning, IUD there as part of your program. And lastly, the first few weeks post-delivery, support breastfeeding, ensure that every EPI visit, women who tested negative are retested. And for those who are on ART, 6 monthly viral loads are done. Early infant diagnosis, birth PCR, 10 weeks PCR, 6 months PCR, 18 months rapid test, 24 months. Initiate as soon as possible. Yay, I can't go beyond this, but yeah, this was today. it's a program I'm very passionate about, and I hope that you have managed to grasp. It's a very busy program, you know, PMTCT. If like this, do this. If like this, do this. But you have to go and read the guidelines. You know, if you don't read the guidelines, you're going to have a problem because patients, when they present between the lines. You know, you have to figure out, okay, how do I handle this? How do I do that? But you have read the guidelines, you know, and then we are there. People like me, we try to respond to calls and WhatsApps. It's not easy because sometimes we are teaching and stuff. But I encourage you to really embrace this program. Yeah, you know, I don't know. Is there someone from the PMTCT program? I see, says Nomsa, you are there. Is there anything you want to add? Says Nomsa, I've given you talking rights. I don't know if you want to add 1 or 2 words. We still have some few minutes.
Okay, thank you, Dr. Mawela, for this very informative session. You know, this is my heart. Okay, I have a few comments about women, about PrEP. Please, let's make sure that women of the childbearing potential who are at risk of HIV infection are enrolled on PrEP, but please counsel them before, and she must be willing to be put on PrEP. This does not exclude pregnant women. We do put them on PrEP as well, but we should make sure that we manage them appropriately, especially during delivery. We've had cases where their babies were done PCRs when the mothers were negative, so we must be sure. There is a circular that I wrote and circulated. Yeah, we've had cases already. Okay, and then again, there is information. We've got the PMTCT guidelines separately, and then we've got the consolidated ART guideline, which has PMTCT in it. But for us not to be that confused, let's please concentrate on the PMTCT guideline because it's very clear there. And then, Doctor, the issue of locked drops, I got confused whether you were talking about the general patient now or the pregnant woman when you were saying that she had more than 1 locked drop, so we need not switch her. And yet the viral load was still above 1,000, was 9,500. Maybe if you can respond to that later, yeah. And then, yeah, with the high risk babies, we separate them, high risk and low risk. The high risk, like you said, it's babies born of unbooked mothers who got tested during labor and they are positive. We start them on dual prophylaxis. But let us not forget to the issue of AZT, that it causes anemia. I found in one facility, a baby has been on AZT for 7 months, and that baby was so anemic. We had to refer the baby to the hospital. Yeah. What we need to continue with, it's nevarapine, as long as the mother is not suppressed. But with AZT, it's 6 weeks. We stop AZT, we continue NVP, yeah. And then cotrimoxazole, we continue as long as the mother is still breastfeeding. And then we stop it post-cessation of breastfeeding. And with the 18 months test, it's now universal. Officially, I know we started as Pumalanga, the universal testing at 18 months. And then let's remember to confirm the positive 18 months test with the PCR test until the child is 24 months. Meaning that if we test a baby at 18 months, if it's positive, confirm with a PCR test. Or you test a child at 20 months. If it's positive, confirm with a PCR test. And then lastly, I have a lot.
Petty list.
Yes.
Okay.
The gene expert colleagues, let us make sure that we do a gene expert on all pregnant HIV positive mothers. All of them qualify for a gene expert. Thank you very much, Dr. Mawela.
No, thank you very much. I see Kate is saying there's a Mamukete Sekonyela. Also, Mamukete, you may unmute from Free State. She's also a manager of the program. I don't know if she's got one or two words or points she wants to emphasize. Miss Mamukete Sekonyela, are you able to unmute? I don't know. Yeah, thank you.
Good evening, colleagues, and thank you, Dr. Lesego, for giving me the opportunity. Can you hear me?
Yes, loud and clear. Thank you.
Okay, Doctor, no, I don't have anything with me because I joined very late, but the information is so informative. What I can just add is in relation with information management. Can the colleagues please don't forget to use the code when doing the viral load during, I don't know if the doctor maybe touched on that because I joined late. During pregnancy and at postnatal, when you take any viral load, you use the code C hashtag PMTCT, and at delivery we use the code C hashtag delivery. Yeah. That's the only, yeah. And then another thing that I forgot is that there's a time that there might be a time where at delivery viral load is missed. When at postnatal up until 6 weeks, we still use the C hashtag delivery, but up until 6 weeks.
Up to 6 weeks, yes.
Yes, thank you.
So if a delivery viral load is done a bit late for one reason or the other, within 6 weeks, we can still use the C hashtag delivery code. All right. Thank you for that. Yes. Thank you. I did cover it, but I'm happy that you have emphasized it. So I really appreciate your comments as well. And Palesa, don't go and commit murder. Palesa is so passionate. She says she will kill anyone who fails the mother and the baby. I understand the emotions around that, but please, we need you in the system so that you can help us to improve, Palesa. But I think I get your message very clear. I think Ms. Nomsa has emphasized a lot of things. Maybe let me run through some of the questions that are on the chart. Mary Adam, you are saying, what was the viral load to have a transmission of 1.7? Mary, those were patients who had a viral load above 8,000. I will share the report as part of the feedback, and you will read it very nicely. But there were two groups of patients: those who had a viral load between 50 and 8,000, and those who had a viral load above 8,000. So yeah, it's answered. Sorry, Mary, I saw your comment there. Guidelines suggest that we do a pap smear if less than 20 weeks. Yes, I know that now we can do early pap smears, and then 6 weeks is still an opportunity post-delivery. Thank you for that. Code for 6 months postnatal, it's a C hashtag PMTCT. It's the code you use for antenatal and breastfeeding. Then there's just a different code for the delivery viral load, which is C hashtag delivery. I think I got it right. In our ANC, we have been doing viral loads a month post initiation of DTG. Yeah, you know, the issue is doing viral loads early. You need to be able to interpret the result. For example, if it's suppressed, it's easy to interpret, but if it's 5,000, what does it mean? Because you would have tested your patient a bit early. Some of them are on their way to suppression, and maybe says Nomsa, your comment around this group. If you look on the slide, if you can see the slide, you'll see that if the first viral load is up and the second one is up, we switch, but you have to consider the log. So when you look at the two viral loads and you're comparing the log and there is more than one log drop, you have to repeat the viral load in 8 weeks. And I tell you, this is not the adult algorithm. It's specific for the PMTCT program. Because remember, in adults and children who are non-pregnant, we don't even look at logs. We just, and the reason is, remember, pregnant women, we give them a very short period of time, 4 weeks to suppress. So more than one log drop might mean that the patient is on a journey towards suppression, and that is what the guidelines say. So it's exactly as is from the guideline right there. So that's why we compare the logs. It's so that we determine which patients are truly failing and which ones are on a path towards success, but maybe we tested them a bit early. So it's kind of like buying time for this group of patients right there. So I think you're okay. I think we have answered that. What can you do if the mother tested positive during breastfeeding and you initiate? Okay, Amkelwa, those who are staying behind just for 5 minutes, there's at least one scenario I will do with you, and then you'll see that question around there. Khadifeli, it seems like you have an interesting case. If you can just drop me a WhatsApp on that particular case, I'm going to share my number on this chart, 0576 So just for case scenarios, drop it, and then so that I can help you with that particular case, because I think it has a lot. With regards to stopping DTG after completion of TB, can it be 2 weeks? So we are not stopping DTG, Tolani. We are just reducing from a twice daily dose to back to the standard dose, which is a daily dose. So you do it 2 weeks from the time. So if someone completes TB treatment today, you continue with the DTG 12 hourly for 2 weeks. After 2 weeks, you can then take it back to a daily dose. So I hope you got that. I know we are behind time. There's just one principle which is very important. If I don't discuss it, I won't be very happy with myself. We will come back and do more case studies, but there's just one case study which I want to discuss with you. So yes, it's a very simple one. It's Beauty here. You see Beauty delivered a baby 10 weeks ago, right? So the baby is 10 weeks old. Now Beauty, the mother, is tested positive for the first time in the postnatal phase, and she is breastfeeding her infant, because that was a question from one of the questions in the Q&A. Yeah, Amkelwa Dunge, that is your question. So you must separate the two. Have the mother, have the infant. Then start and say, okay, the mother just tested positive. What do I do? You do post-test counseling. You encourage her that she needs to take ARVs. She agrees. You initiate her same day, on ARVs. Hopefully, you're going to initiate her on TLD. You do your baseline test, your creatinine, and your CD4 count. You also need to do a gene expert, like as Nomsa said, and then also other tests. For example, if she has never received a pap smear, you might want to do it. You have to discuss family planning with her and offer her hopefully one of the long-acting family planning options. Do a proper physical exam, stage her. If she's got any opportunistic infections, treat them. If she qualifies for any opportunistic prophylaxis therapies, remember INH prophylaxis, cotrimoxazole, or even fluconazole prophylaxis, we want to keep the mother healthy and well, but she must be started. And after 3 months, you do the viral load. Yes, she has delivered, but PMTCT program is not about the antenatal phase. PMTCT starts from preconception up to 24 months. So she's still within the program, and in the program, when we start ARVs, 3 months time, we do the viral load. Now, the infant is there. The infant was born 10 weeks ago, but the infant is exposed to HIV from the mother. Is this infant low risk or high risk from getting HIV from the mother? The answer is high risk. Why? Because the mother is breastfeeding. The mother has just tested positive. She probably has a high viral load. And we have just started the mother on ARVs. TLD, she's likely to suppress in the next few weeks, but today she's not suppressed. So this infant, what do we do? You do a PCR test today. We want to know the status of the child, right? You do a PCR test today. You start the child on high-risk prophylaxis, nevirapine and zidovudine. You're gonna do zidovudine for 6 weeks. Nevirapine, you'll continue until you get a viral load that is suppressed from this mother. You should never leave the child unprotected, right? If after 12 weeks you still don't have a viral load, you are not stopping nevirapine until you get a viral load that is suppressed. The child is 10 weeks old, therefore the child is eligible for cotrimoxazole prophylaxis. So you start cotrimoxazole, you do a PCR, you start nevirapine and zidovudine, you make sure that the immunizations are up to date, you make sure that the child is growing, development is growing, the head circumference is okay, you examine the child, make sure that the child, if there's some symptoms or something, those things are treated. So that is the principle around PMTCT. And we will have a follow-up where I will just do a lot of scenarios to show you how PMTCT can present differently in between the lines, and your understanding of the principles, not necessarily cramming it, but understanding that you have a mother and the infant. You must always protect the infant. You must always test the infant. You want to keep the mother healthy and alive. And can we give AZT and COTRI together? Yes, but you need to monitor your child for anemia. But luckily, AZT is only for a short period of time. Hopefully, by the time things start to get a bit hectic, you would have completed 6 weeks of AZT. Baite Badi. I'm hoping I'm pronouncing your name nicely there. All right. Colleagues, thank you very much for joining us this evening.